It is well established in the clinical environment that in Asia A there are two subgroups. One, with the preserved spinal reflex activity with decreased muscle tone, and second is larger than the first with moderate and severe spasticity. In this presentation, we shall provide evidence the degree of spasticity in the Asia A is the result of surviving conducting white matter through the injured zone to the network below the lesion. In the 250 subjects study of post-traumatic spinal cord injuries, it was shown that there are no standard lesions and that each case is distinct. Complete transsectional lesions are rare, and often some residual descending conducting axons are preserved and able to provide influence in the central state of excitability of the spinal cord below the clinically complete spinal cord injury. There is an advantage to applying surface EMG in synchronized, simultaneously recording of time and side distribution of motor unit activity. This modality provides subclinical motor control information within spinal cord activity above and below injury. There are two specimens of two different subjects. On the left is the specimen of the acute condition where we are seeing the white preserved conducting tissue. On the right specimen, we see the end result of structural modification where the anterior and posterior belt is conducting white tissue, providing delivery of brain-generated impulses to the network below the injury. From this illustration, we can make the following conclusions. In the intact and incomplete lesion of the spinal cord, the brain and spinal cord control can build up integral of movement, spinal cord brain, from the components of originating in the brain and the spinal cord. However, in the incomplete spinal cord injury, residual brain influence can be demonstrated below the clinically complete to the spinal cord injury as the components of movement integral of the spinal cord brain. We can see two events. The first is the polyelectromyography recording during an attempt to volitionally perform a contraction. It shows that muscles are paralyzed and only small activity in the right hamstring after 1 minute appears during the reinforcement maneuver with the neck flexion. After repeating 3 times the same reinforcement maneuver, we set, with latency of 2 seconds, a multi-segmental spastic discharge in all previously recorded muscles. As expected, every reinforcement maneuver will have a different recruitment profile in the residual descending system. There are significant differences if the reinforcement maneuver is a Valsalva maneuver, deep breath, compared to this profile of discharges elicited after neck flexion and classical Gendrassing reinforcement maneuver. The right side shows responses in three groups of spinal cord injury subjects with different degrees of volitional muscle control. It is seen that the reinforcement maneuver can be effective in absence of volitional control of muscles. The opposite results of volitional facilitation is suppression of spinal reflex withdrawal in subjects with clinically complete but neurophysiologically discomplete lesion showing their single and average of the whole group. The next series has been done with stimulation of spinal reflexes, where we are demonstrating that by changing frequency of stimulation and maintaining the strength, it is possible to modify from sustained tonic motor unit activity, rhythmical activity, when the stimulus repetition rate is changed from 6 to 24 Hz. When we apply progressively increasing stimulus strength with the same frequency, we are seeing expansion of tonic responses from hamstring to the other muscle group, total tibial anterior and triceps surae. When we change frequency from 6 to 30 Hz, then tonic activity is modified to regular bursting rhythmical activity. Here we examine the effect of interaction between elicited responses in one lower limb with 10 volts stimuli applied. This added a passive movement from flexion to the extension. As can be seen, the effect is different even when both sides are stimulated with the same strength. An example where sustained stimulation of activity augmented treadmill stepping rhythmical activity. In the following slide, we examine the effect of epidural stimulation of lumbar posterior roots in the spinal cord. Effected by applying constant 25 Hz frequency and at the same time increasing the strength of the stimulus by 5 volts every several seconds, it is seen that by adding segments and increasing population of responding units, we can alter pattern responses from tonic into segment to the rhythmical into 4 segments. Here is revealed that after spinal cord injury, a variety of motor outputs can induce the same kinesiological pattern. On the left is schematic of EMG patterns recorded during the performance of a voluntary multi-joint motor task by a healthy subject. Top right, 3 different spinal cord injury subjects, T8, C3, T7, level of the lesion, attempts to perform the same task, able to execute 3 different patterns of movement with 3 different neurocontrol strategies. Bottom right, the additional 3 subjects accomplish the same clinical movement with different neurocontrol strategies. Conclusions. We have demonstrated that it is possible to elicit movements to post-traumatic clinically complete paralyzed muscles. Clinically complete injury may be converted to discomplete with the reinforcement maneuver or with electrical stimulation. Our findings of several hundred Asia A group have shown 60 to 80% of clinically complete spinal cord injury subjects are discomplete. Neuropathological findings showing that post-traumatic spinal cord injuries are not standard but individual and distinct. Clinical and laboratory methods should be developed to determine profile of the injury and the underlying mechanisms of spasticity. Post-traumatic spinal cord injury has a variety of profiles of motor control which can result in the similar, if not nearly identical, kinesiological profile. Evidence clearly indicates that restoration, augmentation of control of volitional activity, and spasticity is waiting for protocols based on understanding underlying mechanisms of clinical syndrome.